let's go ahead and start with intros.
Dr. Tim Murray, founder and CEO of Solstice Health. We're a direct primary care, direct surgical care facility with 5 locations in the Milwaukee market.
Hi, I'm John Steinlage. I'm the Vice President of Clinics at Anovia Health, a direct pay practice.
Hi, Nicole Hemkes. I am the owner and medical director of AdvocateMD. We're a direct primary care in the greater Madison, Janesville area. We have 4 clinics and 8 physicians.
Good morning still. It's still morning or noon? It's noon now.
Yeah.
Afternoon. I'm Dave Usher. I am the founder, owner, and medical director for our clinical practice called ReforMedicine, which we started 14 years ago in western Wisconsin. We're in Eau Claire, Hudson, Menominee, Chippewa Falls areas.
Okay, so the goal for this session, just to be clear, is not so much about like a DPC 101. I think a lot of folks have a sense. We're going to learn and talk more about kind of each of you specifically in your practices, but what we really wanted to do was deep dive into if you just put DPC in a plan and sort of as a bolt-on and set it and forget it, you're missing the high impact that it can have. So we really want to think about and talk through today ways that you all, or DPC specifically, can act as a medical director, so to speak, for a health plan, and talk about sort of some do's, some don'ts, some perspectives that you all have in that. I've been asked to start the panel with the question from the previous Q&A. So I'll read it, and then if any of you feels really passionately, I'll let you pick this, whoever wants to really answer this one. What programs are you seeing to assist with the behavior change that needs to go along with GLP-1s to assist with outcomes and adherence for weight loss? I feel like we feel very passionately here. Yeah. What programs are you seeing to assist with the behavior change that needs to go along with GLP-1s to assist with outcomes and adherence to weight loss?
I'll take that one if you like.
Yeah.
I am a board-certified family physician. I'm also board-certified in obesity medicine. I've been doing obesity medicine for 20 years, and we have a program that we integrate into all of our direct primary care contracts, which we've been doing basically since we started with employers 13 years ago. And I've been kind of following this along, but basically the essence of it is GLP-1 as an agent in the body is designed to go up in response to in order to control your blood sugar, and GLP-1 drugs, our GLP-1 receptor agonists, are designed to do that, but to not ever go back down. So they work by reducing how much you eat, but they also help lower your blood sugar. They affect an area in your brain that affects hunger and so on. Your native GLP-1 will go up and work for you if you're not toxic from sugar and starch in your diet. So our entire program is built on a reduced carbohydrate diet and eating adequate amounts of protein. And it's that simple, truly. I'm happy to talk to anybody about that at any time for hours and hours if you like. But that it really is that simple. So GLP-1s in our program are always if not preceded by, they're accompanied by a very low carb, adequate protein diet, and that's our approach.
Thank you. Anybody else want to add anything to that?
I think I share in his sentiment in most areas of that. I'm a GLP-1 hater, just by default, because we started our business based on prevention and based on wellness. We use a program called Ideal Protein, which has a lot of benefits to it. I think the big issue that we have in our day and age is that we eat too much. It's not necessarily a disease as we would normally think about diseases. The average North American consumed about 5 pounds of sugar in the early 1900s, and currently we consume 150 to 200 pounds of sugar per year. So if you can't understand what the problem is, then you're stuck with GLP-1s. So I think, as Dave was saying, starting at an early age and helping people understand that, transitioning to, if you're in a later stage in life, doing something like their weight loss program or Ideal Protein to be able to help reduce that, change pancreatic dysfunction at that level, I think is where you're going to really start to see measurable change without having to use these higher cost medications. The other big issue I would say too on GLP-1s, and we can debate it after hours, when you work in the operating room, one of the mechanisms of action is to decrease gastric motility. So when you watch patients vomit and aspirate in the operating room, and you're not careful to assess that preoperatively, that increases your healthcare costs. But also when you see the GI guys, that GLP-1s as a GI guy's like best friend because they're increasing all their endoscopies several fold. You'll see that continue to go up. So whatever savings you have with GLP-1s on one side, you're going to increase your healthcare spend on the other side. So best course of action is avoid them altogether and actually start teaching patients how to eat.
Thank you. Yeah, I think pinpointed it. Happy hour, so you all should just get a drink early and then be ready because I have a feeling a lot of people are going to come find you. I'm going to combine a couple questions here for the sake of time. I'm so excited to moderate this panel. So my family in Texas, we're all patients of DPCs, different ones because they have different sort of specialties. It took me 6 years to convince my mother in Illinois to join a DPC. She was really convinced that her Blue Cross doc was like the best in the whole world. And when she finally figured out, I think she's a little closer to understanding what I do for a career, but it's really like put her on a path to saving her life. So very passionate about DPC. I also, though, in the industry side, see it almost miss the mark. Not that the DPC practice does, but the way that we engage with DPC inside of a health plan and optimize it through the other systems. So you're going to see a lot of those questions today geared towards that. Quickly, if we could start at this end, could you share just briefly, the way I'll combine the questions is essentially to say, like, why DPC? And not necessarily a more traditional like model for you, and why that's important to you, and sort of your DPC philosophy.
Direct primary care, when we launched 14 years ago, was simply a cash pay practice, transparently priced. And my theory was people will pay for their health care if they'll pay something for their health care if they know they can know what the price is and not be stung by surprise bills at the end of the month and so forth. So when I left my previous practice, which was within the system, the idea was if we cut the crap, remove all the unnecessary overhead that is involved with insurance billing and so forth, we can drop our prices right down and post them on the wall, just like going to McDonald's. And that worked very well. And then employers said, hey, can you post some prices for me? And we started working with employers directly. And just knowing that what their employer's purchasing with direct primary care is actually health care and not merely insurance. And so people can come in, if not $0, $10 or $25 or whatever the plan decides. Those people come out of the woodwork, and all of the pent-up demand and the deferred care and so forth, you just see this. And you really feel terrible for those folks for a second, and then you're so happy that they are actually in your front door. So the philosophy is justice.
Wonderful, thank you.
I worked as a fee-for-service insurance-based doctor for about 10 years before starting the direct primary care. I think all of us has experienced the burnout and the seeing 20 to 25 patients a day and the paperwork associated with that. And so this direct primary care model is a slower pace. Patients get more time, doctors get more time. It's a way more fulfilling way to practice medicine. And I think in terms of the DPC philosophy, and I know there's a mixture of ideas about charging per visit, membership prices. I personally think there should be no costs associated with the visit because I think that incentivizes people to come in. Cost is never a barrier to coming in, whether it's $20, $50. We see now with patients how cost is a barrier when they have a high deductible health plan, right? They're scared about what the cost to see, whether it's their primary, their specialist. They don't know that cost until months later when they get that bill in the mail. So in this direct primary care model, we try to remove that barrier of cost and better access and all of those things. So our philosophy is to do the membership model. We also are trying to differentiate ourselves from the big system. So what we see locally in the Madison market is that it's taking 6 months, 9 months, 12 months to get an appointment with a primary care doctor. So I presented to an employer the other day and I said, so you're paying for your insurance every month, but when you call to get an appointment with a primary care doctor, they can't see you for 9 months. Now, how are people not up in arms about that? So if we can differentiate ourselves from the system, if you get an appointment in days or a week, we spend an hour with you, you have a card where you can call or text that doctor after hours. That does not exist in the insurance-based system. So aside from all the cost savings part of it, the access, the quality, the time, you cannot find that anywhere, no matter how much you're paying for your insurance. So that's how we're differentiating ourselves.
Well, thank you.
I would agree with all that, Nicole, and many people who think they have a doctor in the big systems, they don't functionally have a doctor in the big systems, because if they call, they're never going to be able to get in with them. And there's exceptions to that, of course. Based on what was already said, what at Anovia, what our secret sauce is access. We answer the phones. We get people in same day if they need that. We're available and we spend time with people. And also, after they leave our clinic, the follow-up, we keep the inertia of, especially if it's a complicated visit, an initial visit, many things were talked about and done, labs were ordered, we follow up very closely on that. And we also focus on managing referrals very closely. So it's a matter of time and availability, in short.
I agree with everyone on the panel. I'll just add that the average face time with a physician in this country is 7 minutes. And you cannot do healthcare in 7 minutes. You cannot do wellness in 7 minutes. You can't educate in 7 minutes. And that's why we started our company based on a wellness model. When we did that, we realized very quickly that when you control pancreatic dysfunction and oversecretion of insulin, which is a fat storage hormone, it increases cholesterol synthesis, arterial or smooth muscle, all these things. That's the catalyst for diabetes, high blood pressure, high cholesterol. When you do that, you quickly remove cholesterol medications and diabetes medications, and down the line some high blood pressure medications, and there you have DPC. And you're doing something to actually care for the patient and change the course of disease as opposed to adding medications into the mix. I think that all of us here are working to keep patients healthy, not put them on medications, not work with this polypharmacy approach that the traditional healthcare system does when you only have 7 minutes to do it, because you're treating a problem with another pill for the side effect of the first pill. So that's sort of the catalyst, I think, to be able to spend more time with patients.
I'm going to start down there again and work our way back. So you didn't get much prep time, but I am going to allow this one back to you. So can you share an example? And I would say, whatever you're comfortable, either a very specific example or speak more philosophically on this one. But an example where a role of a DPC practice or an independent surgery center has prevented unnecessary spend or care, but still ensured that the patient got what they needed. And the reason I ask that question is I think there's a misconception on the insurance side of things that by either redirecting or shifting, it's really plan sponsors saying, we don't necessarily, if the member doesn't get it, it's okay, we're okay with that. So that there's a care gap. And I see it on the risk side a lot, that's a misconception. So can you think of an example where you save the plan money, or the involvement of an independent practice saves the plan money, and the patient got what they needed?
Yeah, I mean, there's all of us up here probably have a million examples, simplistic clinical examples that we have to deal with every day, or we had to deal with every day in dealing with insurance, is having some 21-year-old sitting in a cubicle tell us what we could or could not do, or how we needed to do it, or what protocol we needed to follow. If you have, for example, time to spend with the patient and you can sit and delineate a good history and physical exam and realize that you really don't need to get an x-ray before you do physical therapy, before you get an MRI, then before you see the surgeon, you can go straight to the MRI, not only saving the plan $3,000 or $4,000, getting the MRI done right away, getting them in to see a specialist right away, getting them to see surgery right away, back to work sooner. You're decreasing all of these sort of forward-looking expenses for the employer and the individual. So I think those are fairly simplistic ways. Catastrophic savings. When you look at an employer that comes to you and says, hey, we've got this patient who's on an infusion medication and it's going to cost us, it's cost us in the past $40,000 or $50,000 and they need to have it again. Can you guys do this? The answer is yes. We just have to get the medication, and we either do that independently or we'll work with a plan like Self-Fund Health to be able to source those out of the country. But sitting in a chair at our clinic, for example, might cost $2,000. We've had patients come in for different infusions like Ocrevus and things like that. And again, from a medical director standpoint and a clinical standpoint, you don't have to spend 6 hours of chair time at a hospital so they can feed you a sandwich halfway through the day. If you look at the package inserts and look at the way that these medications can be infused, and you can do it in an hour and a half, you've got a really, really happy patient that gets out of the clinic in an hour and a half, and the plan only gets charged $1,500. as opposed to 40,000. So there's so many different
Great example.
things that we.
Yeah, go ahead.
I'll use an anecdote. Just this morning, I spoke with a surgeon about a patient I saw yesterday who had a complicated cholecystectomy, and there was concerns about infection. There was an ER visit in between. The ER shot off referrals, as they will do, made sure the patient was safe. The patient is doing very well now. Staying involved in clawing back referrals. I never would have done that in the past. It is a bit of an art, of course, but that's where we shine in direct pay. I spoke to the surgeon this morning. We agreed the patient didn't need 2 other referrals, and patient was happy about that. Surgeon, who's the main player here, was comfortable with that, and I never would have had the time to do that in the past. So that happens all the time at Anovia. And it is something that we're encouraging our younger providers to understand, to stay involved, where that's not something that they ever did in the past.
As Tim said, there's a lot of these examples, but I can think of a few just off the top of my head. We had a patient from a company that had just started with us, and she was scheduled to get a total knee replacement in, I think, 30 days. It said, let me just go in and see the DPC doctor first and see what they think. She didn't really want to do the knee replacement. So anyways, the doctor that saw her decided to try prolotherapy. So we have a physician in our practice that does prolotherapy and also refer her to physical therapy. Long story short, she had 90% improvement with the prolotherapy, avoided a total knee replacement, which we know could be $20,000 to $80,000. We had another patient who was told by the system that they had malignant melanoma. They needed Mohs surgery. They came in and got biopsy in our office. They wanted a second opinion. They did not have malignant melanoma. They had a benign condition. It's amazing too when you have the time to actually talk with the patient and ask them more questions like, how long has this been there? Has it changed? You know, again, in the system, you're kind of pushed through, and so it's like a reactionary thing. Okay, well, let's refer you to the dermatologist. Yeah, let's remove that for you. And then last example is I had a patient personally once that diagnosed an acute appion. We sent them to a freestanding independent imaging center that's one of the sponsors. They did the CT scan. We saw that they had an acute appy. I called the local hospital. We avoided them having to go through the ER. We directly admitted them to surgery. She had the surgery done. She got discharged, I think, the same day.
Yeah, great examples. Thank you.
For those of you who don't know, a cholecystectomy is a gallbladder removal, and an appy is an appendicitis. Both of which are
Everyone's Googling furiously.
acute surgical medical conditions that almost all the time wind up in the OR getting treated surgically right away. We have countless examples. The biggest one I can think of that could commonly occur was having a patient who had bilateral or both sides of her hips were arthritic, bad osteoarthritis, which is the common variety that we see. And she was consulted on under the system and told that she indeed had terrible arthritis and was going to need hip replacements. She was on one of our employer plans, and because of the nature of how we work with the employers, we kind of understood, okay, we need to divert or steer or at least offer them the other options and make sure that they're aware of their other options. So we use their care navigation service, and it turned out that this lady was incentivized to use a high value, if we would think of it as a tier 1 orthopedic group. That was a little bit down the road. She would have to drive, 50 miles or so. But when she did this, the employer paid her a couple $1,000s per hip. But in 2 weeks, she went and spent only $50,000 for 2 hip replacements instead of $120,000. She herself put $4,000 in her pocket, and her husband got to stay in a fancy hotel for a few nights while she had her surgery and recovery. That's one case that just sticks out in my brain, but it's representative of so many missed opportunities to really save an employer's health plan, gazillions, really.
I know some examples. I know if we had Leslie and team up here, they have tons of examples also. Just a show of hands, since we're all like ready for lunch, so y'all need to wake up. How many people here have seen an independent or a DPC doc, or a close family member has? Oh, good, amazing. So, do you remember the first time? Because I will just tell you, the first time I did that, and she was not on her laptop. She just like sat down and she had this sunflower pen. I'll never forget it. And she was like, "So tell me about yourself." And I was like, "Am I in an interview or a doctor's appointment?" It was like the most bizarre experience. And I'm
Candid
like looking
camera.
at the clock. Yeah, I'm looking at the clock like, isn't someone in room 4? Like, what are we? It's very different. And like with my mother, she has a lot of health issues. And what she realized was she would try to plan how much she could say in the 7 minutes, like Dr. Tim said, and she couldn't get it all out. And now she's like, he asked me questions. I never even thought those two things were connected. And so just in her life, the impact of just being able to think and not be rushed, I think is a consistent theme about the impact that it can have. So that's a great segue, what you were sharing to, there's lots of ways that you can kind of tie your clinical decisions to savings for the plan. What are some ways or ideas that you have, whether things that you've done in practice or you've seen in practice, for employers to help increase that impact? How can you all, in working with an employer plan, have a bigger impact on either the employee, specifically the member, the dependent, or the plan as a whole? I'll start down there. Go ahead, yeah.
I mean, a lot of it's engagement. I think that's the most critical part of it. I think a lot of people, when they hear all of us talk and they hear, whoever it is talking about putting a plan like this together, it's like we're going to implement this and we're going to save money. Not true. You have to engage with your employees. You have to have the leadership of the group effectively lead by example. And that translates down and transcends into the employee population. But there are a lot of local companies. I know Steen is going to be talking later. But doing things like health fairs for your employees and getting them engaged with the different providers in the networks, whether it be physical therapy or your DPC or your surgical network, whoever it may be, if they can't see us and talk to us and touch us and ask us questions, they're not going to come to us. They're just going to go to the big green building, somewhere down on 94. And that's not where you want them to go if you're trying to make effective change within your employer group. And so that's really the main thrust of what we do is engagement, because if more employees are engaged, you're going to save more. Let's put it this way: if they're more engaged with the preferred provider network within your plan, you're going to save more money. The more employees it is. If you have less employees engaged, you're still going to be on that same wheel of trying to figure out, are we going to save next year? Are we going to have more expenses next year? So you really need to get that client engagement. If that includes all of us to come and do lunch and learns or to come and do health fairs and things like that, I think it's important to communicate with the employer group and the plan and the broker and really work together to provide something that's going to help engage the employees.
At Anovia Health, we try to stay very involved with the many companies that we have. We have individuals, but most people see us based on a company. And we stay involved and help them along wherever they are. Some of our companies have many direct contracts, many referral strategies that we just need to, basically follow 99% of the time. But there's a lot of opportunity for cross-pollination from one company to another. This worked for this company, and we try to hand out those ideas when appropriate. And some of our companies are not very far along in working on all the referral strategies and working on them with ideas about incentivizing something as easy as a quick trip gift card can go a long way. People respond to quick trip gift cards. So whatever they're interested in, we have a lot of ideas. If they don't have any, some of our companies really have all the ideas already, and it's just a matter of following in that partnership.
I was also going to say, I think engagement is number one for most employees, patients, this is going to be a new concept for them. So they're going to have to kind of, have a little bit of a leap of faith to try this. So you have to have a good strategy to engage them. You have to have the key players, they both on the HR side, the insurance broker side that are, championing this. If you don't have the key players that are invested in this, it usually doesn't work out very well. And that goes along with designing a plan design where you're actually giving your employees some skin in the game, right? Because your health insurance costs are going up year after year. They should have some investment in, controlling those costs. So if you design a plan where they have a $250 deductible and a $500 out of pocket or something, they probably are not going to have a lot of financial incentive to, go with the DPC. They're going to continue to still follow doing everything at the hospital. So you have to design the right plan. You have to have the right key players. You have to have a strategy to engage your employees so they come in and try us. I always say to companies that if they can come in one time, it's our job to sell this to them once we get them in the doors. But if they can come in one time and spend 45 minutes to an hour with a doctor, they're greeted when they walk in. They're not having to type into a computer screen. They're not sitting for 20 or 30 minutes in the lobby. They're being brought back to a room. They have a doctor, as Maddie said, that looks at you, that listens to you, all of those things. And then they will have a very different experience and hopefully continue after that.
What was the question? What do we do to...
Essentially, what's the best way to optimize your involvement?
Yeah. Oh, thank you. So our approach in thinking about this basically is, as Dr. Hemkes said, utilization. That's kind of I think that's the insurance term, the industry term. If we can get them through the door once to just experience the difference, you may not spend an hour with me. You may only take 5 minutes. And for God's sake, maybe that's all you want to spend, but you get in today, or maybe you get in tomorrow. And when you get in, you feel like whoever was there seeing you actually heard what you said. I might not have much to say, doctor. I'm only here for this thing. And maybe it's only a 5-minute visit. I mean, sometimes you can see people in 5 minutes. I'm not going to, and I'm not saying you guys do this, Nicole, either, but if they want to get in and out, I don't want to spend an hour with them. I just want to take care of what they need because they need it. I need them to get wins. For them, the big win is coming through the door the first time. And that's how you as the employer win. You got to get them through that direct primary care door the first time to experience the difference, to understand that something is different here, and it'll feel different. And you should feel like you're going to get better care and better outcomes and all of those things. But to me, that's kind of it. And that's what drives utilization. And that person may have been there for 10 minutes, but they'll go tell 5 of their friends that, wow, that was different. That was pretty cool. You should go check it out. Mm-hmm. And that will drive that escalating utilization.
I would describe it as a more luxurious medical experience. Even if it's not like a concierge level, which I think people also talk about, you get so much time and attention, where so many of us are used to like getting 5 minutes with a doctor, that it feels like luxurious. Like, is this okay that I've been sitting here for this long? Or you can text the practice for some of them, or you can go online and submit that is just such a different level of high touch than I think most people are used to. I don't think anyone in here would argue about the fact that everyone wants more time with their docs or wants their employees to have them. But it sounds it's almost utopian in some ways for those of us who've had to deal with the operational headaches. So I want to shift a little bit, and I'm not trying to paint a negative picture, although I am the ultimate cynic. I think it's important to talk about what we have to do to operationalize incorporating DPC. So can you think of something operationally? It could be in how you work with the TPA or an employer group, more on the technical side. It could be specific. It could be something you wish you could do or you're working on now that maybe you haven't done yet. But what's something operationally we can do to make this work and not make it so hard? Or do you feel like you have a pretty good way of incorporating it? What's a way you work with self-fund? Different things that you could share about, because it all sounds great, but how do we optimize it from an operational perspective? I'll give you guys a second. I know that was a tricky question. If you'd like to start.
Sure. We have a partner care team. We have dedicated people. Diane, who's here with us. Hi, Diane. Embarrassed her, sorry. She does a really great job. We have a small group of people who are dedicated exactly to making sure that the employer gets what they need, whatever that is. Because there's so many different variations, and like direct primary care practices, self-funded health practices, when you've seen one, you've seen one, right? And there's a million different ways. Everybody's got their own thing. That's why they call it self-funding, because this is a thing you own. And direct primary care practices are kind of that way. It's kind of, we're independent. If you're independent, which is, I think, the best way to go. Direct primary care practice, you kind of are one direct primary care practice. So everybody can do, we can practice independently, be free to do what we want to, what we need to for our patients, and not feel like we're being pushed to do kind of corporate whatever we do there. But one of our most important things is just dedicated people to make sure that those employer partners are also heard, and that they get the time they need, and they get the data they need, and the resources they need to make sure that their plan is successful.
Which is different than just an office billing coordinator, which is what so many like health plans, they only hear from, well, so-and-so got a bill, and they call the billing coordinator, and it's either like the doctor, the nurse, or the billing coordinator. And it's such a different concept.
Right.
Thank you, Dr.
It's a concierge for the employer.
Yeah.
One thing that just came to mind, and I'm not sure if this actually answers the question, but data reporting is something that's always, I think, a challenge. It's a need. Employers want more of this, and we've always been pretty good about reporting utilization data. But now, we have a company recently that wants more performance-related data, and I think as physicians, we're always a little hesitant to have to report these sort of things, because then I personally get a little scared. Is that going to become then pay for performance, which we know there's a lot of challenges there. But I think that getting better about how we report data, how we all have separate EMR systems, and again, based on diagnosis, based on outcomes, how do we report that in a primary care setting? I think that's something that we're going to need to work on, going forward.
That's a great example.
Yeah, I would definitely agree with that. I think specifics at Anovia, I think one of the biggest challenges we have where we feel that it's something we're good at, which is managing people's care, be it a referral or a new diagnosis, is I think being able to, based on where they are along that thing, is keeping the communication lines open. We feel we're good at it, but boy, it's still the thing I think that is one of the bigger problems or things we could always be better at. What frustrates us the most, I guess, when we maybe didn't completely meet expectations. I think also this personally, with my experience at Anovia, balancing episodic care and disease management with wellness, where I still think that we're being brought into not forgetting to focus on wellness and rather just taking, prescribing medications, doing those things, not having a strategy around GLP-1s. I think that's there continues to be a lot of inertia in the other way. It's something that we're striving to be better at.
I would say, much like Dave was saying, there's no two DPCs alike. I think there's no two companies alike. And not having an insurance monkey on our back, so to speak, it allows us to be a lot more flexible with an independent company's needs. Patient populations are different with every company. A manufacturing company patient population is going to be much different than a tech firm, for example. And so being able to meet them where they need to be with on any level. Some companies will come to us and say, hey, we can't do this DPC thing, but we saw your MRI rates are $315. Can we do that with you? Sure. Why not? Why can't I do that? So you have, and I think within this space, we have the capacity to do more. And I think being able to engage with the employers on an individual basis is really, and again, that includes engagement. Engagement is the key in how one company does their employee engagement versus another company. They may need us to be there, and the other company may not. They may need a video visit or something along those lines. So just being able to be flexible with every different employer, I think, is really important.
That's great. I'm going to combine the last two questions. They're forward movement focused, keeping in mind what Jonathan was talking about. So, and I'll remind you if you forget the question. Part one is, we have a mix of employers, self-funded and not, brokers, consultants, providers, et cetera. What does the market, and we can just say the general regional market, or you can say healthcare in general, what does it look like in the future if every health plan was centered around DPC or independent docs? That's part one. And then part two is, for those people out here who are curious about it, what's one word of advice you have for them about what to do? Is it come find you? Is it talk? Is it research? So what does the movement look like if every health plan is centered around DPC or independent docs? And then for those people who are curious, or maybe they just needed to go more towards, they already have you on their plan, but they're not really using you, what's your word of advice for them?
So about 65% of the population works for a self-funded company. And I think the hospital and insurance industry control most of that. If you implement a direct primary care in those 65% of the population, you'll see catastrophic change, and the hospitals and the insurance companies will start to listen. So I think that's really important to recognize first and foremost. And the second part again was?
Word of advice for either someone curious or wanting to implement you.
So since Jonathan was overly blunt with his title phrase, I'm going to say something a little blunt. Put up or shut up is the bottom line for all of you. I can't tell you the number of years we have spent walking into a boardroom or somewhere else, and I can pick out 2 people who will kill a deal. And I won't mention who they are, but I think everybody knows who they are. And we hear all the time, well, we love DPC. DPC is so great, or we love direct surgical, and nobody does anything. You actually have to do it. You actually have to look at your colleagues, your other surrounding businesses, and say, hey, I heard you guys were doing this. Does it really work? Or call us and ask us questions. Don't just write it off and kick the can down the road to the next year. You can't look at year one, okay? You have to look at what you're doing now as years 3, 4, and 5. That's when you're gonna really see exponential savings. That's when your employees are gonna feel those savings because their premiums aren't going up every year. So if you're approaching this as like here's year one, we're gonna have $1 million in savings. You're going to fail, okay? And you're going to feel bad, and then you're going to want to fire someone right away. But if you're not going to do it, don't complain about your 18% increase next year or the year after, because I've been hearing this for 13 years now. It's like, I know we talked about DPC 6 years ago, and we got an 18% increase again. It's like, well, that's because you're not listening. So you really have to take a leap of faith, for lack of a better phrase, but just look at the data. Look at the data that Self-Fund Health can give you, or any of these other brokers that are really working in this space, because it's real. I mean, there is real savings across this panel. There's tens of millions of dollars of savings just in this small panel here.
That's great. Dr. John?
I think I would just simply add, which really is, I guess, just going along with what you said, is in primary care, think big. Because I also have been seeing companies, trying to buy urgent care, trying to, have different limited strategies. And, well, we probably don't need mental health, we don't need this, we don't need that. Just get the whole package and find a primary care that will do all that and is comfortable doing all that. That would be just my simple advice.
Great. Dr. Nikki?
I'm trying to remember the parts of the question, but I think as far as what it would look like if everyone was utilizing DPC and if a lot more companies were self-funded utilizing DPC, I think we would see hospital systems that were a lot smaller, leaner, right? We don't need these gigantic, fancy hospital buildings. We don't need to perform a bunch of these outpatient services in hospitals. We need those to be outpatient, independent centers for those. So I think hospitals need to, or hopefully will become leaner. I think all the docs sitting up on this panel, we need larger DPC practices. Having a bunch of 20 independently owned DPCs in one city, in my opinion, is not the solution. We need direct primary care practices that are kind of locally, geographically, multiple clinics. This is easier for employers to work with. In terms of advice, I think that everyone sitting here obviously sees that there's a need for change. So I think that just kind of recognizing that change, isn't always easy, and it will be you all sitting in this room that make the change. It's not going to be the hospitals and the insurance companies that make this change. They are benefiting off of the current model, right? So the hospital lobby and the insurance lobby, it's not going to be our politicians that make the change. It will be employer groups, consumer groups. It's going to be a grassroots effort. So you all have to be the ones that have put in the work to do this from the beginning, and that's what's going to lead this movement forward.
Part one.
Part one was.
What would it look like if every health plan was?
Oh,
set
if every
around
health plan, yeah. What would it look like? I'm kind of a strategy thinker. I'm kind of a big long-term, high-level thinker, and there's a lot of high-level issues here that honestly we haven't even touched. And to Mad's earlier credit, she put up there the whole thing about there are certain things you can control and certain things you can't. However, in order to make this kind of thing a reality, the only thing that forces that change is this continued Thelma and Louise race towards the cliff that American healthcare is on currently. And until enough people experience enough pain with the cost of healthcare, the system will just continue to drive people desperately, employers desperately, direct primary care doctors desperately into some new model. The system as it exists only, and so the point is, the root cause is Medicare. Medicare is the root cause of all of this. It creates price floors and regulations and things that will never, ever, ever, not ever change. So DPC-based model is going to be an alternative to that reality. We can't expect that those systems are going to change. There are too many entrenched interests. The hospitals, the insurance companies, insurance brokers, no offense to those of you who are that. Everybody's kind of incentivized, or has been, to play the game the way the game has been played. And that benefits everybody but the patient and primary care doctor. So direct primary care, if we're going to do it, has to come along with not an approach of commoditizing primary care and thinking, oh, primary care should be really cheap and this is all about saving money. What it should really be is what most of the world does. You pay more for your primary care because the value of it is so high. By paying more for this, we have to pay way less on the other end. The system is built the other way currently. They try to ratchet us down and make us see more patients, but we're spinning off death and destruction financially everywhere in the way the system works. So thinking differently about those things over the long haul is, when I see what it looks like, it's gonna look like two alternate realities. One is the system as it exists now, and the other is going to be this other world that we're trying to create. We're not trying to tear that one down, we just can't live in it. And over time, more and more people won't be able to live in it, not employers and not their employees.
Or that's the Academy Award music. He's our statue. Before we wrap, I just wanted to say I'm hearing here this theme about there's a lot of buying power in this room. And in brokers and employers and there's a lot of buying power. Just power in general. And you, as consumers, we hear all the time about how we control where our dollars go, and that controls and impacts the movement. That's a theme here. The other thing I'll say is there's a misconception, it's a big part of book 2, that the doctors are the ones making all the money. I can tell you, and I'm sure they all have opinions about this, that is not the case. All these people are folks you could come and talk to who are got into medicine to help people, I can tell. And there are entities making the money, and it's not primary care docs. So I encourage all of you to come and talk to them some more, but I also encourage you to take this and do something about it. Either do it or be quiet, I guess, to Dr. Dim's point. There's buying power here, and y'all need to use it.